Yes, it's my privilege today to introduce our speaker, Dr. Nancy Collop. She's director of the Emory Sleep Center. She graduated from Edinburgh University in Pennsylvania and got her MD from Penn State College of Medicine in 1984. She completed an internship and residency at the Medical College of Virginia, now known as VCU, Virginia Commonwealth. She did a pulmonary critical care fellowship at the University of Florida and held academic positions at the Medical University of South Carolina, the University of Mississippi, and Johns Hopkins before coming to Emory. She's held an amazing number of offices, including Secretary Treasurer and past president of the American Academy of Sleep Medicine. She's presently editor-in-chief of the Journal of Clinical Sleep Medicine. She's on a ridiculous number of boards. I won't even try to list them all. She's received a lot of honors, including being on the list of best doctors in America, which I think says it all right there. She received the Helmut Schmidt Award from the American Board of Sleep Medicine, the Nathaniel Kleitman Award for Distinguished Service from the American Academy of Sleep Medicine. The real question is when she ever finds time to sleep. So I'm going to turn it over to her now and let Nancy take over. Thank you.
Welcome, everybody. I'm having a little trouble with my transmission, so I hope someone will let me know if I'm breaking up, and I can try maybe a different tact. But I'm gonna. So anyway, thank you for the introduction. I'm gonna take you through a whirlwind through sleep and talk at the end a little bit about sleep disorders, but hopefully you'll all have something that you can relate to in this talk. I was telling Gray that usually most of my talks are pretty well received because everybody can kind of relate to sleep because we all do it. So here's a picture that I stole off the internet of the 3 pillars of good health, and would argue that they include exercise, right? And then obviously good nutrition, but often that 3rd pillar I consider sleep. You know, this poor little fella down here, he's kind of sleeping on the job, and that 3rd pillar has fallen off because maybe he's trying to do too much and not getting enough sleep. So yesterday, as I was getting the final touches on my talk, I Googled sleep, and now you get almost 2 billion hits for sleep when you Google it, 2 billion. So obviously it's an area that everybody's pretty interested in. And there are estimates that up to 70 million Americans suffer from a chronic sleep disorder, with as many as 20 million having sleep apnea, 10% with some restless leg symptoms, and 10 or more percent of chronic insomnia. And I heard a little bit of the discussion as we were getting ready for the talk. And if what I heard is what everybody's thinking about, it certainly gives all of us a little bit of insomnia, I would hope, and probably some heartburn too. Sleepiness and not being well rested obviously has implications for your quality of life, but it also can be much more dramatic. And we know that as many as 20% of car crashes are associated with sleepiness. Obviously, that's a hard number to know because, it's very difficult to track if someone falls asleep or nods or has a micro sleep before there's an accident. But certainly pre-COVID, and I haven't seen statistics since COVID, but car crashes are the #1 cause of death at every age between 2 and 34, and used to be the 3rd behind heart disease and cancer in terms of life years lost. Many car crashes are also associated with alcohol. And I said many are associated with sleepiness, sometimes in addition to alcohol. And these crashes tend to occur late at night on major highways at high speeds and disproportionately involve young males. In addition to motor vehicle crashes, there's a number of fatigue-related accidents that have occurred over the years. I'm sure many of you will remember these. The Union Carbide plant in Bhopal, India, in which 40 tons of methyl isocyanate were released. There were over 500,000 people exposed, and they estimate the deaths at close to 4,000, probably many more than what were acknowledged. Many of you remember the nuclear meltdown at TMI at 3 Mile Island. I remember that very well. My sister lived in Harrisburg at the time. The Exxon Valdez, when the tanker crashed into the rocks and that released a lot of oil that was felt to be related to pilot fatigue. Many air crash accidents, including the Continental Airlines flight outside of Buffalo, where 50 people were killed. And in that same year, Air France, where over 228, they were somewhat attributed to pilot fatigue. And then even in trains, there was a train crash in the UK in 2001, where a gentleman named Heck fell asleep in his car on the train tracks, and 2 trains crashed, and 10 people died from that with 80 injured. And of course, many of you remember the Metro North accident. There's a picture of it there where the Metro North was trying to go around a curve, which was, they were supposed to go to 30 miles an hour. They were going much faster than that. And 4 people were killed and 60 injured. And that ultimately found to have obstructive sleep apnea. An old Institute of Medicine report suggested that over the past years, Americans are sleeping about 20% less, with over probably 20% to a quarter of them in shift work. And we're working more hours, with doing more jobs, watching more TV, and using obviously the internet more, which results in later sleep times and less sleep. Okay, so we're going to do a little audience participation. On a regular work week, or if you're not working, how many hours of sleep do you typically get? Do you get more than 8, between 7 or 8, less than 7, but more than 5.5, or less than 5.5? And I want you to think about that for a minute and keep that in the back of your mind as we go ahead. I have another question here, if I can get my computer to advanced. I don't know why I'm having so much trouble today. It's usually not like this. Figures. I'm gonna go back now, hang on. Okay, so this is a scale that we use quite often in the Sleep Center. It was developed in the Epworth Hospital in Australia. It's called the Epworth Sleepiness Scale. And I want you to add this up in your head for a minute here. So the question is, how likely would you be to doze off or fall asleep in the following situations? Now, this is not feeling tired. This is actually dozing off or falling asleep. And I'm going to give you 8 different situations, and your choices are that 0, you would never doze off in that situation. 1, that you would have a slight chance of dozing. 2, a moderate chance of dozing. Or 3, a high chance of dozing. So the highest score you can get is 24. Obviously, the lowest score you can get is 0. So understanding that, add this up in your head. So if you're just sitting and reading, how likely would you be to doze off? Watching TV, sitting inactive in a public place. Not sure any of us are doing that much these days. As a passenger in a car for an hour, lying down in the afternoon, sitting and talking to someone, sitting quietly after a lunch with, or in a car while stopped for a few minutes in traffic. So add that up in your head. What's your final score? It can be between 0 and 24. Okay. So is your score between 0 and 6? Let's go back, 0 and 6. It's between 0 and 6, you're doing a good job. You're probably getting enough sleep. If you were between 7 and 10, that suggests that you're mildly sleepy and you're probably not getting enough sleep on a nightly basis. If you're more up in the 11 to 15 ratio, that suggests you're moderately sleepy, and you're either really shortchanging your sleep or you may have a sleep disorder. And if you're over 15, it suggests you're very sleepy, and I'm watching you're not sleeping while I'm talking to you. So how can you tell if you're getting enough sleep? So if you're finding yourself yawning a lot, I don't know about moodiness or depressed mood these days. That's a bit of a challenge to not be a little depressed. But if you have fatigue, irritability, or you notice you're having difficulty learning new concepts or having forgetfulness, trouble concentrating, lack of motivation, maybe even clumsiness. I'm going to talk a little bit about how sleep is associated with appetite, carbohydrate cravings, reduced sex drive. But some things that I like to tell people as far as markers of sleep deprivation is, if you have to wake up to an alarm clock every day, that suggests that, you might not be getting enough sleep. If that alarm clock goes off before you wake, that suggests that you're not getting enough sleep. If there's an hour difference between your weekend and your weekday sleep time, or if you're finding that you have to use a lot of caffeine to stay awake during the day. So just some historical studies I thought might be interesting to throw out there on sleep deprivation. So Marie here, she looks kind of like she would have been mean, and in that picture anyway. And she showed that when you sleep deprived dogs, that they died of hypothermia, or developed hypothermia and died within a few days of sleep deprivation. And then in 1959, this gentleman, Peter Tripp, underwent prolonged wakefulness for 201 hours to benefit the march of dimes. And he was also given a large dose of stimulants to stay awake. And it was noted that after a few days, he began to hallucinate, seeing kittens, mice, and cobwebs, became paranoid, insisting the electrician had dropped a hot electrode into his shoe. And later in 1964, so this picture is a picture of Randy Gardner. He's standing there with probably whom we in sleep medicine call the father of sleep medicine, Bill Dement. But at the time that he did this experiment, he was a 17-year-old, and he had stayed awake for 11 days for a high school science project to break the Guinness World Book of Records. And when he finally did go to sleep, he slept for almost 15 hours. Okay, so there are some animal studies as well. This is a classic experiment where we're on these platforms, and you can see they have their instrumented, they have electrodes, and they were monitoring their brain waves. And whenever the mice would fall asleep, the plate would spin and it would wake them up. Okay, so trying to get back to my little mice here. So what you'll see is that when they sleep deprive these mice, that they develop these lesions on their paws. And then over time, while their metabolism and their energy intake went up, their weight went down, and their body temperature went down as well. Other studies have looked at hormones that are affected by sleep deprivation, and there's a number of hormones that are affected by sleep deprivation, including growth hormone, leptin, ghrelin, TSH, thyroid stimulating hormone, insulin, and glucose levels, as well as glucose. So here's a picture of a study that looked at 3 different hormones: plasma growth hormone, plasma TSH, and cortisol. And you can see that when there was acute total sleep deprivation, so that's no sleep for at least 24 hours, there was a lack of the plasma growth hormone. And even with sleep restriction, so 4 hours a night for 6 consecutive days, there was a blunting of the growth hormone with sleep extension showing that to come back. Growth hormone is actually secreted during slow wave sleep. Similarly with TSH, you can see, interestingly, with 1 night sleep deprivation, there was an increase in TSH, but with prolonged sleep restriction, it was again a blunting and recovery with recovery sleep. And then plasma cortisol also, in a stressed situation, Leptin levels and ghrelin levels are also affected by sleep deprivation. This is a study that looked at leptin levels after 2 days of 10 hours in bed versus 2 days of 4 hours in bed. And you can leptin reduced when there was sleep deprivation, and that signals the brain to eat more calories, and ghrelin increased with sleep deprivation, which also induces or triggers appetite. And of course, you're all probably familiar with statistics on looking at sleep and death. It's similar in men and women. The solid line here represents the amount of sleep hours. And remember, I asked you that question earlier, and you can see that most people are sleeping between 7 and 8 hours in this study, with 7 about the standard. The X is the more, and you can see this U-shaped curve. So short sleepers and long sleepers had increased mortality in both men and women. And then a very famous study looked at chronic sleep deprivation, where they did the people in the study were sleep deprived. You can see different levels, 4 hours of time in bed versus 6 hours versus 8 hours. And they had to do a task every morning when they woke up. And what they found was, obviously, the more sleep deprived that they were, the more lapses they had in the task. However, what was really interesting about this particular study was that while and they asked the participants, how do you think you're doing? And while there was a little bit of a decrement initially, over time, the participants said, oh, I'm doing great. So people tend to be, this study suggests that people are unaware of how sleep deprived they actually are. And I see this all the time, certainly in my clinic. And then again, those relationship with hormones, short sleep's a link to obesity. There's a number of studies that have looked at this, meta-analysis of 45 studies of over 600,000 adults and 30,000 people showed this correlation between short sleep and obesity, both in adults and in children. And a different study doing actual sleep studies showed that there was a relationship between slow wave sleep, or that deep sleep, and BMI. So the less slow wave sleep you had, the higher your BMI was. And other studies suggested that obese adults slept almost an hour and a half hours fewer than lean subjects. And it's also been confirmed in a different study using actigraphy. Athletic performance also appears to be affected by the amount of sleep. So this is a study looking at the ability to do different weightlifting maneuvers, and they showed that after 4 days of sleep deprivation, that there was some decrement in the ability to lift these weights. And then this was 1 night of sleep deprivation for those of you tennis players. They required the tennis player to hit the ball in this little box here, and looked at how they did with 1 night of sleep deprivation. You can see both men and women had a reduction in their accuracy, and even when they let them had caffeine, it didn't improve it. And then this one, what looked at basketball players, they looked at sleep extension. So this is a little bit different. They allowed the basketball players to sleep longer, or ad lib. You can see that they actually got better in their improvement in different shots and their self-rating in the game. So sleep extension actually improved in performance. So next I'm going to switch and talk about what happens when we sleep. And so going to sleep is not like switching off a light. It's an active process. And there's a lot going on in your brain when we go to sleep. Why do we sleep? What's important? It helps us obviously solidify and consolidate our memories. We know that after you sleep, you retain information and perform better on memory tasks. And it also obviously is important for bodily function. It assists in restoration and rejuvenation of muscle, nerve, and other body tissues, as well as hormone synthesis, as we've already discussed. So when we sleep, there's really two important parameters that determine when and how much we sleep. One is really easy to understand. It's called process S, or the homeostatic drive. And it's easy. It's like getting hungry or thirsty. The longer you go without sleeping, the more this drive builds. So in humans, our homeostatic drive, we want to be asleep about a third of the 24-hour period. We want to be awake about 2/3 of the 24-hour period. And sleep deprivation of any kind, either acute or chronic, will increase that drive. And that drive can be satisfied by sleep at any hour of the day. That drive is modulated by your circadian rhythm. So even one-celled animals have a metabolic cycle. There's temporal compartmentalization in the cell, and different processes will turn on and off during the day. Complex animals like humans have much more entrained and synchronized cycles of physiologic symptoms. They're actually, it's probably determined by your genes, we know now. There's clock genes, and actually a couple of years ago, the Nobel Prize was won for the doctors that determine these clock genes. And this allows us to tune our metabolism to day-night schedules. And there's this interplay between metabolism and the circadian rhythm. So I always think frequently about circadian rhythm with relationship to sleep, but it's a relationship to all processes, no matter what organ you're looking at. It's important for all organs. So the circadian rhythm in humans is entrained by light. And so when light hits our eye, there's photosensitive receptors in the back of our eyeballs. And when it becomes dark, those sensors send signals through what we call the retinohypothalamic tract into a small center in our brain called the suprachiasmatic nucleus, that then a little relay through the superior cervical ganglion to the pineal gland. And the pineal gland then starts to release melatonin, and that occurs when darkness occurs. So now if you think about this, and it should make sense to you. So these two processes in action. So the sleep need here is that homeostatic drive. So, you know, here we are, we just, hopefully you all got a good night's sleep, and the sleep need is increasing during the day because now we're awake, and these chemicals are building in our brain. But the sleep urge, which I'm calling the circadian rhythm, is also playing a role. And so, you know, what is it, about noon now? There's this little bump in your sleep urge that occurs in the early afternoon hours. That's where a lot of societies will take siestas because of the sleep urge, the circadian rhythm. But it starts to drop down again, and the sleep urge is actually lowest in the evening hours. However, that's when the homeostatic drive is continuing to rise. So you'll see what happens is what gets us to sleep in the first few hours is that homeostatic drive, but what keeps us asleep in the early morning hours is that circadian drive. And so that's why we sleep, and how long we sleep. That's what determines it. So when you go to sleep, or if you come in and have a study, we're going to measure your brain waves. So there are certain changes that occur in your brain that we can pick up by these brain waves. So as you can see, the awake brain waves are kind of low frequency, low amplitude, somewhat high frequency. And then when you go into non-REM level 1 sleep, you can see there's the frequency becomes slower of the waves. In non-REM 2, which is what we spend most of the night in, there are some characteristic waves. We call them sleep spindles here, and these big K complexes here to the middle of the screen. And then in that non-REM delta sleep or deep sleep, we have these great big waves. And then REM sleep looks a lot like non-REM 1, but what happens in REM sleep is your muscles in your body are at their absolute most relaxed state. So if you look at sleep across the night, you'll start out awake, and then in the first part of the night, you'll have most of the deep sleep, and that's driven by that homeostatic drive. Whereas REM sleep is driven by the circadian rhythm. And so your first REM period occurs about 90 to 120 minutes into the night. and then it will get progressively longer as the night goes on. And so you can see that the deeper sleep occurs in the beginning and more REM sleep in the early morning hours. That's why you may often wake up out of a dream, because you tend to have more of your REM in the early morning hours. And as I said, there's a big difference between REM and non-REM sleep. You saw the picture on of the brain waves, but non-REM sleep is thought to be more important for that physical restoration. It's a quiet brain. The body, you can move around in non-REM sleep. Tend not to move around a lot, but you're moving around much more so than you are in REM sleep, which REM is thought to be perhaps more important for mental restoration and memory. It's again driven by that circadian pressure. And while the brain is almost as active as it is during wakefulness, if you're looking brain metabolism, the body is essentially paralyzed. So again, just to contrast non-REM from REM, in REM, you have a much more irregular heart rate, respiratory rate, blood pressure. I mentioned the skeletal muscle tone is absent. What's interesting about the skeletal muscle tone is obviously your diaphragm keeps working because we keep breathing in REM, which is important. And your eye muscles keep working. That's why we see the rapid eye movements. And that was how it was first described. Brain oxygen consumption I mentioned is increased in REM compared to non-REM. Your ventilatory responses, so your sensitivity to oxygen and carbon dioxide, are reduced more so in REM. You become a little more like a snake, poikilothermic. And that again is why when you wake up, if the temperature in your room's cold, you may feel very cold if you're waking up out of REM. And then of course, sexual changes occur as well in REM. Sleep across the lifespan, what's interesting to note is that REM sleep in babies and toddlers takes up much more of the time than it does in adults. And so it's about 50-50 in infants. We actually call it active and quiet sleep. But once you hit about 10 years old or so, the amount of REM you have remains really stable across your life. And so even older patients or older individuals should still have about 20 to 25% REM sleep. What happens as we get older, though, is we do have less of that deep sleep. And so, and this is a little bit worse in men than women. We have more awakenings and arousals, more changes in our shift. Remember the hypnogram I showed you before, this patient has a lot more awakenings for this individual. There's fewer cycles, there's less sleep efficiency. Sleep efficiency, we define that by from the time the lights go out to the lights go on, how much of that time are you actually sleeping? And there's a little bit of phase advancement, I'll talk about it in a minute. So you want to go a little early to bed, but also get up earlier. And there's also tends to be more napping that occurs. And what's interesting is women tend to have more complaints about their sleep or irritations with their sleep compared to men. But most of the research, of course, in sleep has still been done in men, although I think we're catching up a little bit with that. So back to that question of how much sleep do you need? Most sleep organizations would agree now that you need probably at least 7 hours a night. Most adults need at least 7 hours a night to promote optimal health. And as we said, here's that little graph I showed you earlier, a little cleaner, that U-shaped curve with the amount of sleep and mortality. We also, as I mentioned, it's associated with weight gain, obesity, diabetes, high blood pressure, stroke, and depression, getting fewer hours of sleep at night. And then we talked about the subpar performances, error, and more accidents. And interestingly, it probably also has effects on your immune function. And lower sleep amounts are associated with lower pain tolerance. So you tend to have more problems with pain. So what about some helpful tips to y'all for getting a good night's sleep? So I'd recommend don't eat a large meal before bedtime. If you are hungry, we don't want you to go to bed hungry, but eat a light and somewhat healthy snack. Always exercise regularly, maintain a healthy diet. Remember those 3 pillars that I started the talk with? Very important. Exercise really helps people sleep. That's been shown over and over again. You'd really want to avoid caffeine. many people have different tolerance rate levels to caffeine, but any sleep doctor worth their salt will tell you should avoid caffeine probably anytime after lunch. Alcohol is often used to help people sleep. It's probably one of the more common hypnotic agents that's used. But alcohol, while it will help you fall asleep, it actually makes your sleep worse as the night goes on. You tend to have more REM rebound, and it also makes sleep disordered breathing worse. And so we always recommend avoiding alcohol before bedtime. Obviously, you want to reduce your fluid intake to reduce the amount of times you have to get up to go to the bathroom. And it's important to try to keep a relatively constant sleep schedule. You should get up around the same time every day, even on the weekends or on vacations. And of course, that's assuming you're getting enough sleep. As I remember, that 7-hour is what at least a goal could be. So most people get up around the same time every day. So I always tell people to kind of set your wake up time and then work to make sure you're getting that 7 hours of sleep at night. You want to limit exposure to bright light in the evening. Remember, we talked about that circadian rhythm, particularly blue light is very stimulating. So you don't want a lot of blue light in your eyes. Keep those electronic devices off. At least 30 minutes, I'd say, the longer you can keep them off, the better. And if you have trouble sleeping, a TV will not make it better. So I have all kinds of patients who tell me I have to fall asleep with the TV on. And a good sleep doctor worth their salt would say you should never have a TV in your bedroom or watch TV in bed when you're getting ready for sleep. Establish a relaxing bedtime routine, whatever that might be for you. A cooler, because part of your circadian rhythm is a fall in body temperature that helps you fall asleep. So it's better to have a cool room. And fans might help. Fans cool the temperature as well as provide a background noise. I don't typically recommend showers or baths right before bedtime, unless you want to knock it off at the end with a very cool shot of cold water. Because again, we want your body temperature to be falling to enhance sleep. You shouldn't really get into bed unless you're sleepy, because then you're just going to get frustrated. And if you get in bed and you don't fall asleep, you should get out of bed after about 20 minutes and go do something relaxing until you're sleepy again. Use your bed only for sleep and sex. Don't eat, watch TV, do your taxes or things like that while you're in bed. Here's a few tips that might help you fall asleep if you're having trouble with that. You've heard of this diaphragmatic breathing or muscle relaxation. So you can use the 4-7-8 breathing technique. So you exhale through the mouth, inhale through your nose for 4 counts, hold your breath for 7 counts, and then exhale slowly through your mouth for 8 counts. And then repeat it until you're asleep. That can help. This is a very effective way to help relax. And then another one that I heard many years ago and I will use sometimes is rewind the day you just had in your mind, starting when you first woke up. And so just like a little video in your head, try to remember it in as much detail as you can. And then hopefully before you get even to lunchtime, you'll have drifted off to sleep. So I'm going to spend the next few minutes, and now my computer's working great, so it makes my life so much better. So I'm going to spend the next few minutes just talking about some common sleep disorders. So insomnia. So what is insomnia? Well, everybody probably listening today has had an occasional poor night of sleep, stayed up too late, woke up too early. It doesn't mean you have insomnia. It just means you didn't get enough sleep that night. Insomnia means that you chronically don't get enough sleep, and then that has an adverse effect on your daytime ability to function. And insomnia we can define as difficulty falling asleep, difficulty staying asleep through the night, or sometimes waking up too early in the morning and not being able to go back to sleep. And what's interesting about chronic insomnia is most people that have chronic insomnia will not be sleepy, but they'll complain about fatigue. So they're fatigued because they're not getting the right type or kind of sleep. There's a number of things that are associated with insomnia. Certainly stress. We always look, when we evaluate patients with chronic insomnia, always look for other sleep disorders that may play a role. Mental disorders, depression, anxiety, very common. About half of chronic insomnia will have a psychiatric diagnosis. Medical disorders and medications can result in some problems, things like asthma that's waking you up, or pain, certainly, pain syndromes. There are certain medications, obviously, that are not conducive to sleep, like stimulant medications. Substance abuse also can cause sleep problems. We'll talk a little bit about circadian rhythm disorders. Not having a good sleep environment. Do you live next to an airport or a train station? Are you worried about your safety at night? Those things can obviously play a role in your sleep. Shift work and, obsessing about sleep. That's very common in people with insomnia. It's kind of a self-fulfilling prophecy. When they wake up after a bad night's sleep, they start to worry about, oh, am I going to have another bad night's sleep? Now, I put this slide in here not to tell you I'm going to go through all the chemical reactions that go on in your brain at night when you go to sleep, but to just point out that it's a very complicated process. There are many different centers in your brain that are involved. There's hormones and neurotransmitters moving in and out of different brain centers. And I like to say sleep is like a symphony. Everything has to work in coordination, and that's why no one sleeping pill is going to be adequate to replicate sleep. And so what sleeping pills do is they work at one part of the process in your brain and try to help with that. But there's no sleeping. I mean, you see how complicated sleep is, different levels you go through, different times of the night. Obviously, no medication can replicate that. So when people have chronic insomnia, they often come to us with medication, but we really prefer behavioral management over pharmacologic. Most of the hypnotic agents that are used for sleep are not really meant to be taken long-term. As I said, there's a number of different types of behavioral management. We'll often refer people out to a psychologist if they need really intense cognitive behavioral therapy. We use things like stimulus control. The idea behind that is you want to force the association of bed and bedtime with sleeping. So again, using the bed for sleep, go to bed only when sleeping. If it doesn't occur in 15 or 20 minutes, get out of bed until you're drowsy. Do something relaxing, not with a bright light. Don't want to turn on the news, and avoid napping. Sometimes we use techniques called sleep restriction or sleep compression. And the way that works is that we'll estimate basically how much sleep you're getting based on sleep diaries. Let's say you estimate you're getting 5 hours of sleep and you want to get up at 6 o'clock in the morning. We'll say, well, you can't go to bed till 1 o'clock in the morning. But you still have to get up at 6 o'clock in the morning. And again, that technique really is banking on that homeostatic drive to help you get to sleep. And then once you've consolidated your sleep in that 5 hour period and you're sleeping most of that time, then we give you back a half hour or 15 minutes or however the therapist wants to do it. But that's a very common methodology for behavioral management of insomnia. And then obviously mindfulness, relaxation techniques, meditation, and the diaphragmatic breathing that we talked about. So trying to get you to relax. And then eventually if we fail at our efforts, then we may refer people on to a psychologist for cognitive behavioral therapy for insomnia. I want to touch just for a second on circadian rhythm disorders. So we talked about circadian rhythm disorders. So most of the time in humans, our circadian rhythm is a little bit more than 24 hours, like 24.1 hours. And so, with normal cues and what have you, we stick to that 24-hour rhythm. But what happens when people have circadian rhythm disorders is their clock's a little bit shorter than 24 hours or a little bit longer than 24 hours. And so sometimes they'll have trouble either falling asleep or falling asleep too early and waking up too early. So this is a malalignment or misalignment between the desired sleep schedule and their internal wake rhythm. And, you know, usually we don't have particularly sophisticated techniques for this. There are some research techniques where they actually measure melatonin levels, but it's not really done clinically at this point. So usually we use sleep diaries or actigraphy. Actigraphy is like it's not unlike a fitness watch. It's like a medical grade fitness watch where we get movement and rest periods. And so here's a picture of an actigraphy. The black bars represent movement. And then obviously when you stop moving, we assume that you're asleep or at rest. And so in this particular patient, his actigraphy shows that he goes to sleep at 8 o'clock in the morning, 8 o'clock at night, and wakes up at 2 o'clock in the morning versus the more normal, this is midnight to 8 here, the bars. And so this particular patient, we would diagnose with advanced sleep phase syndrome. These are the LARCs, early bedtime and early wake time. We tend not to see these in the sleep clinic because these aren't people that have problems necessarily. They may not be the biggest party animals, but they're the ones that are, you know, at work early, and but they're not out partying late at night. And so their sleep complaints are typically that they wake up earlier in the morning than they want to. And this is, again, very well described genetic in the genetics of it. There's a familial form. There's probably more than just the PER2 gene, but other forms of gene mutations that lead to this advanced sleep phase syndrome. And the therapy usually is having them sit in front of bright light in the early evening, and that helps delay that melatonin release. What we do see, though, is a lot of delayed sleep phase. So here's an actigraphy of a patient with delayed sleep phase where they go to bed at 4 o'clock in the morning and wake up at noon. So this delayed sleep phase, these are the night owls, again, later to bed, delayed wake time. And we do see a lot of these, and they often will present as having insomnia. And the reason is they have a lot of trouble falling asleep before their body wants them to. And so, but they still have to get up early and, you know, go to school or go to work. And so their usual complaints are sleep onset insomnia and morning sleepiness. Again, they have a little bit of a longer circadian clock. This is very common. It's actually normal in adolescence to have a little bit of a delayed sleep, but it kind of reverses itself over time. But if it persists, then it can be a problem. The one question you want to ask or that we ask patients that we think may have this is, if you can sleep whenever you want, what would that be? And would you be rested? And usually, you know, they'll say, well, yeah, if I can go to bed at 3 o'clock in the morning and get up at, you know, noon, I feel just fine. And that's a clue that they may have this delayed sleep phase. And this, again, has been, you know, enhanced by, you know, all the electronics. And, you know, the typical person that I see that has this problem is a computer programmer, a young adult male computer programmer. That's the very prototypical delayed sleep phase person. And so, again, our therapy in this population is actually giving them early morning light. And sometimes we'll give them melatonin, but it'll be hours before their desired bedtime to help kind of kickstart their melatonin. Very occasionally, and this is really hard to do, we'll do something called chronotherapy, where they will serially advance their sleep time until they work their time around to the desired sleep time. So if they're going to bed at 3 o'clock in the morning, then every few days they'll go to bed a little bit later and a little bit later until they can work their way around. Now, usually it takes like you know, I guess working from home now, you might be able to do it easier, but it usually takes, you know, a couple of weeks to get that advanced enough to where they're at their desired sleep time. So what are some of the other more common sleep disorders? Restless leg syndrome, obstructive sleep apnea, I'm talk a little about. I'm not going to talk about hypersomnia, but I will say that many of the doctors that I work with here are doing research in hypersomnia, and it's a very fascinating area as well. So restless leg syndrome, I'm going to guess, I don't know how many people are on the call today, but I'm going to guess some of you have restless leg syndrome just because it's very common. the diagnosis of restless leg is a clinical diagnosis. What typically happens is in the evening, this is a circadian pattern. So it usually happens in the evenings, and the patient will feel some uncomfortable or irregular or itchy. I mean, all different kinds of sensations in their legs typically, but it can be in other body parts, can be in arms. There's lots of different descriptions of other body parts that can be affected. But this activity or this annoyance makes it difficult for them to fall asleep. And that's why we often see patients like this in the sleep center, because they'll present with more insomnia complaints. Very common to run in families. Other risk groups are anybody that has iron deficiency, because it is associated with iron deficiency, may flare up in pregnancy, people with kidney disease, and in patients with peripheral neuropathies. What the mnemonic that we use is urge. So they have an urge to move that's induced by rest, gets better with activity, and occurs in the evening. And if you think you may have this, this is easily treatable with medication and sometimes even iron supplementation. And so I would definitely talk to your primary care doctors about that if you think you may have restless leg syndrome. Just to finish up with obstructive sleep apnea, this is by far and away the most common sleep disorder that we see in our clinic. Certainly not the only sleep disorder, but the most common that we see. What happens when somebody has obstructive sleep apnea is they go to sleep and the muscles in their throat relax. Initially, there'll be some vibration of those tissues that causes the snoring. And then with apnea, the airway may obstruct or at least narrow to a degree that they aren't able to get air in and out of their lungs. And so this is a picture here of a epic from a sleep study. And what you'll see is this particular person is in REM sleep. Those eye movements there, you can see that's the REM sleep. The highlighted area here is showing the airflow signal. So we usually have sensors under the nose or around the mouth that are measuring air coming in and out of the nose and mouth. And so you can see there's no airflow in that situation. The next box is looking at effort. So the patient's continuing to try to breathe. So there's sensors around their abdomen and chest that looks at chest effort. So the airway is obstructed. There's no air coming out, even though they're trying to breathe. And the oxygen level goes from a 90 to an 81%. And then fortunately, there's a disruption in their sleep that occurs. Sleep resumes. Wakefulness makes the airway open up. Breathing resumes, and then the patient can fall back asleep, and this can happen over and over again. So what happens during the course of that apnea is oxygen in the blood goes down, carbon dioxide goes up because you're not breathing. There's changes in the area around the heart because you're generating negative pressure, which may result in arrhythmias. You can see I don't know if you can see the EKG there right in the middle here, but there's some slowing of the heart rate and then an increase in the heart rate. Obviously sleep fragmentation, and this causes change in both the peripheral blood pressure as well as the blood pressure in the brain. So the signs and symptoms of sleep apnea are snoring, typically nightly and loud, gasping, choking, irregular breathing. Typically none of these the patient is aware of. And so this occurs, while the patient's sleeping. So they obviously, since they're asleep, may have no recollection of what's going on. And usually when people come to see us, it's because somebody else has noticed this. They will note that their sleep's not refreshing. They may have sleepiness. Women tend to have more insomnia or fatigue complaints. They may wake up with a headache. It can cause, mood disorders and even short-term memory problems. Nowadays, we will often diagnose this with a home analysis kit. Not everybody has to come to the sleep lab. Matter of fact, we probably do as many home analysis kits as we do sleep studies these days, and probably more. The home analysis kit is usually only good for obstructive sleep apnea diagnosis, however. So you can't replace sleep labs with these home kits yet. The other thing, I think a lot of people avoid come to be evaluated because they say, oh, I'm going to end up on a CPAP machine. And not everybody ends up on a CPAP machine that has sleep apnea. And as I said, most patients are unaware. And so a lot of times these patients take some convincing that they should come in and be evaluated. And it's very common in certain groups, diabetics, people with poorly controlled high blood pressure, 80+% of those have sleep apnea. Very common atrial fibrillation, people who've had a stroke, very high prevalence. Obviously, it is more common if you're obese or overweight, and patients with Down syndrome have very high prevalence of sleep apnea. And sleep apnea may have serious consequences. We talked about arrhythmias. It can damage the heart. It seems to be there's association with diabetes, again, maybe in part related to the hypoxia and in part related to the sleep fragmentation that occurs. The sleepiness, memory loss, sexual dysfunction, and one of the strongest associations with sleep apnea is that of stroke. And it is the deadliest sleep disorder in that there is evidence that it does increase death, probably not by the sleep disorder itself, but these association with many of these other comorbid conditions. So the treatments, obviously for milder cases, we would suggest that people avoid things that make their sleep apnea worse, like alcohol, sedatives, narcotics. Some patients can get away with positional therapy. This is a picture of a little positional device. There are several out there now. And weight loss can, if you have mild apnea, may be enough to treat it. Of course, CPAP is the most common therapy. It's a CPAP stands for, PAP stands for positive airway pressure device. It just pushes air into the lungs through a sealed system, and that air pressure keeps the throat open and prevents it from collapsing. There are dental appliances. This is a picture of a dental appliance here. You go have this fit by a dentist who has competency in these. They fit on the upper and lower jaw, and you can see this has like a little telescoping rod that pulls the lower jaw forward and opens up the back of the airway. Another very common methodology to treat sleep apnea. And there are some surgeries that are done for sleep apnea. Again, those are very individual. I do show this picture. You may have heard this advertised. This is a hypoglossal nerve stimulator. And so this is the way I describe it. It's like a pacemaker for the tongue. And so basically it's implanted under the skin. There's two wires, one wire that sits between the ribs and measures breathing, and the other wire that snakes up under the skin and the neck and wraps around the hypoglossal nerve that stimulates the nerve to push your tongue out of the way. And so there's a little remote control. You turn this on at night. The sensor tells the stimulator when to stimulate the nerve at what part of the ventilation to push the tongue out. And this is also available now, FDA approved, and thousands of patients have had this implanted as well. So the approach to sleep complaints is first to make sure you're getting enough sleep. If you think you may have a sleep disorder, you should probably first start with your primary care doctor. You can self-refer. I put the number there for the sleep center if you're interested, or you certainly can talk to we get lots of referrals from primary care. And I believe I made it. Let's see. So it looks like my first question is Marilyn McKay. You can unmute yourself.
Okay, unmute and I'm back now, I think. Can you see me?
I can see you. Yes, I can.
Okay, good. That was a terrific talk, and it's always an interesting subject. And I was quite fascinated with the genetic aspect of things. I'm from a family of nappers. My parents could nap. I could probably take a nap anytime. I used to drive from Grady over to Emory and park my car and get there 20 minutes early and take a nap before I went to work in the clinic. So is that common? I mean, are there people that nap? I wake up easily at night when the dogs need to go out, and then I just go back to bed. It doesn't seem to matter.
Yeah. So sleep is very genetically driven, for sure. And so there are good sleepers and there are not so good sleepers. And, I think that doesn't surprise me at all to hear you say something like that. I mean, I observe, I'm not a great sleeper, unfortunately, but it makes me so mad because my husband, he can fall asleep like whenever he wants. It drives me crazy. He's a napper and he can take a nap, and I get so mad. And I'm sure many of you have had similar experiences, but it's probably genetically determined. I mean, obviously you would worry if it interfered, but if it's more like you can sleep on demand, more power to you is what I say. I mean, but it is probably genetically determined for sure.
Yeah, it's refreshing. I mean, 20 minutes is all I need. And I know people that say, well, I can't possibly go to sleep. I'll wake up groggy. And so anyway, I just thought I would throw that in just because I have never heard it discussed. And I know it's true. Thanks again.
Sure. It looks like my next hand raise is from Tolly and Jerry Williamson.
A physician friend once told me that the bed is for two things that begin with the letter S, and struggling and suffering are not among them.
Right. I like that. I'll have to remember that. My next hand is Gretchen Schulz. Can you unmute yourself?
Yes, I can, and I did. Okay. You mentioned along the way, Nancy, that as is so often the case, so much of the research that's been done has been done on men and not women. And that's beginning to be corrected. I'm just wondering whether you and the field have identified any significant ways that areas of sleep and sleep disorder in which women seem to be significantly different than men.
Yeah, great question. And there's lots. So, I mean, again, my interest has always been in sleep disorder breathing syndromes. And there's big differences between men and women there, in that it's very unusual for pre-menopausal women to have sleep apnea. Not that they can't, because many do, but the prevalence of sleep apnea is much higher in men than women, particularly premenopause. So once menopause hits, the prevalence is almost the same with men and women. So they think it may have something to do with the upper airway sensitivity to hormones. Another one is restless leg syndrome. So restless legs is really interesting. It is more common in women, but what we know now is it may be that men characterize it differently, or it presents differently. So they may not have as much, I don't want to say awareness about it, but they may not associate it as well as women do with the sensation. I don't know if it's a different sensation or that doesn't bother them as much, but restless legs is more common in women, but we think that men underreport it. Insomnia is another one. Like I said, more women have insomnia than men. It's much more common in women than men, but men tend to have more problems with their sleep. If you look at like how well they sleep, they tend not to sleep as well as us, but we tend to have more issues with our sleep, and it may be that we're just more sensitive to it. So I think, it's pretty diverse across different sleep disorders. If you look at things like narcolepsy, there doesn't appear to be any type of a male or female predisposition. Parasomnia is the same way, but there certainly are cases in which women and men have different phenotypes, what you have for the presentation of the sleep disorder.
Thanks. Fascinating.
Sure. All right, thank you. The next one, looks like my next hand is Rosemary M. McGee. You can unmute yourself.
Thank you very much for a really helpful discussion. I'm very familiar with sleep apnea and also the likelihood that it might be not diagnosed for women in particular, which was my experience even as a young woman. I'm wondering, and who doesn't fit any of the other profiles. I'm wondering if you have any thoughts or concerns about the long-term use of the oral appliances that are are used to reposition the jaw, as you pointed out, and in terms of the formation of your jaw or the reformation of it?
Yeah, no, that's a great question. Yeah, so these dental appliances have become very popular. As I said earlier, the way they work is they kind of attach to the upper and lower jaw and really use the upper jaw as the anchor to pull the lower jaw forward. If you have the type that's made by a dentist, it's adjustable. So it can be adjusted over time. And, you know, they've been around with us now for many years, decades, really. And so we do have more long-term data, and most of the data would suggest that they do over time cause some skeletal changes in the jaw. And, you know, most patients who have one will have a noticeable change in their bite that occurs over time. But interestingly, in addition to looking at those changes, they also have shown that most people don't abandon it because of it. They continue to use it because it works very well. But yeah, there's definitely been shown some skeletal changes that occur over time with use of those devices. It doesn't appear that there's a lot of ongoing need for adjustment. Sometimes there is, but usually they're relatively small adjustments. So it's not like you're going to keep having to crank your jaw out further and further and further. It doesn't appear that that happens for most patients. The other challenge that sometimes we'll run across is with these appliances is they may cause some tooth loosening. And, you know, some people have to have dental work because they don't tolerate it well, because like I said, it is using the teeth to help pull the jaw forward. So some people may have some issues with their dental, with their teeth. But again, most people who use these do pretty well with them and use them for a long time. All right, it looks like Mr. Jim Keller has his hand raised.
Thank you very much for this talk. When I was an intern, we worked 24/7, and that's not happened anymore for obvious reasons. But there are still people that work shifts. And I'm wondering if any of the work that you've done on sleep apnea can be translated into trying to keep people alert and awake at night who are working night shifts, for example, long hours, nurses included, physicians, other people.
Yeah, no, it's a great question. So there's been a lot of work that's looked at this. A lot of it's military because they have big interests in keeping people awake at certain times of the day or night. And so they actually, the Department of Defense does a lot of research in wakefulness and you know, there are, so what I would say is in general, people that work shift work sleep less and have more sleep complaints. On average, probably an hour less if you look at across studies. There is a lot of interest in using medications to help people stay awake, and nowadays there are medications that are actually approved to assist with shift work disorder. The medications that are used are the most common one that's used is called modafinil, and its sister compound armodafinil. So they can actually be used to treat people with shift work disorder. There are some other ones that are also coming out as far as stimulant medication. Most of these are being approved for use in narcolepsy though, and not necessarily for shift work, but there are approved drugs for shift work. I mean, there are some tips that we give shift workers if they have a lot of problems, you know, related to, you know, using sunglasses when they come out, when they get out in the morning, using melatonin judiciously during the day, you know, to help them sleep and things like that. But it is a real challenge. And again, I think my first questioner said, you know, there are people who are much more adapted to tolerating shift work or sleep deprivation, be it their circadian rhythm or their ability to tolerate sleep deprivation. So we all have different tolerances for that. And And so there are some people that probably shouldn't just be working shifts, you know, and hopefully they select themselves out over time.
How about light therapy? Has any light therapy been applied to this area?
Yeah, you know, it's interesting. There's lots of studies that have looked at using light therapy, and the American Academy of Sleep Medicine has a practice parameter on treatment of shift work disorder, but the evidence is really pretty crappy about it as far as strong evidence for it. But yes, we use light therapy quite often to treat these circadian rhythm disorders. You know, you can buy lights, you know, that have a certain lux to help people either with advanced or delayed sleep phase. I mean, sunlight's great if you use sunlight, but the problem is you can't always necessarily use sunlight when you need it. So yeah, there is some data on light therapy, but it's not the best.
Thank you very much.
Sure. All right, I've got a few more hands here. It looks like Lynn Ganem.
Thank you.
Is that Ganem?
Ganem, you got it right the first time.
Good deal.
Thank you. The stereotype is that as we get older, we nap a lot more. And I'm wondering, and I know I do, but I've always been a napper. Is this to make up for a lack of some kind of sleep during the night, or is it an addition, or is the stereotype not true?
Yeah, no, I mean, people do nap more as they get older. You know, I guess I would ask, when you're napping, are you going to take a nap because you're tired or sleepy and feel like you need a nap? Or is it just, it's time for me to take a nap? If you feel like you have to have a nap, then that may be something to be worried about, that you are not getting the right kind of sleep or the right amount of sleep at night. You know, in general, we sleep doctors are not big fans of naps, unless you're not, you know, getting the right kind of sleep or enough sleep at night. Because naps, again, take away from that. Remember, I talked about that homeostatic drive. So if you nap, it takes away from that homeostatic drive and may make it harder to fall asleep at night. But you know,
I have no trouble falling asleep at night.
well, I was just going to say, if the nap doesn't interrupt your ability to fall asleep at night, then I don't see that that's a big problem.
Thank you.
Sure. Let's see. Next hand up is Jan Pratt.
Okay, I have a question relating to jet lag. Some people seem to sleep on planes. I don't, even if it's a long plane, I really don't. Is the sleep you're getting on plane equivalent to a sleep that you might be getting if you were lying in bed, A? And B, I don't really suffer from jet lag. And I've had a lot of long flights in my life, but I don't seem to suffer from it, whereas other people seem to just die immediately. They have terrible jet lag. Can you speak to those kind of things?
Yeah, sure. So, you know, as we talked about, there's no surprise that people will have jet lag, right? Because you're trying to alter your circadian rhythm.
Right.
To, you know, and again, circadian rhythm is not just about sleep, it's about other things. So when people have jet lag, they'll have other, you know, symptoms associated with it, you know, GI symptoms, or when you get hungry and all that goes along with it. So you asked about sleep on a plane. Well, I've had the fortune a couple times to be able to fly in those first class cabins where you can lay down. And I mean, I highly recommend it if you can do that. Because I think in that setting, you get really, and of course there's free cocktails too. So, you know, but in that setting, I think you can get pretty good sleep. But, you know, sitting in a chair that, you know, maybe goes a little bit back, I don't know that I've ever gotten good sleep in that situation. So, and you know, and you are at altitude, so you're going to have a lower oxygen level when you're at altitude. So, you know, if you have any tendency, if you have any lung disease or any history of, or any problem with sleep apnea, that's probably going to be worse on a plane for sure. most people will suffer from some jet lag. You know, when depending on whether you're going east or west, there are some really nice phone apps for those of you whenever we all get to fly again. There are some nice phone apps that help you with trying to figure out, you know, how to prepare for a long trip. Like you can start to either sleep earlier or sleep later based on which direction you're going, and even alter your diet and when to take melatonin and when to get light and when to stay awake. So I highly recommend if you're traveling and you have problems with jet lag. I mean, you're lucky you don't have problems with jet lag. That's awesome, but most of us do. So I think some of those jet lag apps are actually very helpful.
Thank you.
Sure. Let's see, got a couple more here. Angelica Pohl.
Thank you for a very interesting talk. I wonder if you could say a few more things about hypersomnia. I am blessed with an ability usually to fall asleep, and then with uninterrupted sleep, if I don't set an alarm, I wake up more like 9 hours later. I wonder what kind of problem that might cause,
no,
and whether I should set the alarm and make myself get up earlier.
Yeah. Well, it's interesting. So I'm not sure that that's a problem necessarily, but what's important to understand, and we talked a lot about like what is somebody's sleep ability. It's also probably how much sleep does any one person need. So I said 7 hours, but you know, there's data that many people can do just as well with 6 hours, but some people may need 9 hours. And so there is probably a lot of variability in how much sleep someone actually needs. And, you know, I think, you know, I mentioned like, how can you tell you're getting the right amount of sleep for you is, you know, are you sleepy when you wake up? Do you have to wake up to an alarm? Things like that. But if you sleep, let's say you sleep 9 hours and you're rested the rest of the day and don't need to take naps and feel good, then maybe you're just somebody that needs 9 hours of sleep. I would not call that hypersomnia per se. Now the people that have hypersomnia, you know, either narcolepsy or idiopathic forms of hypersomnia, they never feel rested by their sleep. Or with narcoleptic patients, a lot of times they actually often have very poor nighttime sleep, and they take little naps during the day. So that's hypersomnia, but I don't want you to confuse that with just maybe needing more sleep, because some people may just be longer sleepers.
Okay, thank you. Thank you.
Sure. Okay, let's see. Another hand here is KV Ravikraman. Hopefully I didn't butcher that too bad.
You are talking about circadian rhythm. Is it the correct terminology, or diurnal rhythm is better terminology?
Well, as I said,
because we are talking about
I'm sorry, go ahead.
So it is Q dependent.
I'm sorry, would you repeat that?
We are talking about the sleep-wake cycle, which is a Q-dependent system rather than free-running.
It is in normal circumstances, right? Yeah, so as I said, I guess you have to be careful with circadian, because that is more than just about sleep. So yes, I think we have a diurnal sleep rhythm, but the circadian rhythm has to do with more than just our sleep.
Because insomnia and everything what I was thinking about, when you break the Q-dependent system, then it becomes free running and people can develop any type of symptomatic conditions. That's what I was just thinking about, rather than they lose us because like you have said, people sleep late in the night or whenever they want, so they lose the Q dependent function, and it becomes a kind of, internally modulated by internal clock rather than external clock.
Yeah. Yeah, it's hard to get away from, it's hard to get away from the cue dependence. But there is one condition in which people will free run, which is people that are totally blind, and they can free run, and they will go to bed a little bit later each night. But again, they take cues as well, if not light cues, other cues, Zeitgeibers we call them. So, but thank you.
And one more question that I have got is, during immediately after delivery, the ladies, the way my wife was very sensitive to child noise. Is there is a difference in the sleep pattern, or anybody recorded their sleep brain waves different from before and after?
Yeah, it's a good question. I can honestly say I don't know that literature. Well, I do know that, sleep does a bit during pregnancy, but I don't know a lot about post-pregnancy as far as effects on sleep staging and what have you per se. So I don't want to say because I don't know.
Thank you.
All right, looks like my last hand is Susan Safley.
Yes. My husband is a computer programmer, and he definitely is a night owl. We've been married for 28 years, and he has always stayed up until the wee hours of the morning working, and then he sleeps late. And from what you say, I think he's just he takes his phone to bed and watches it while YouTube while he's trying to go to sleep. I've waked up in the night, I sleep soundly, and he's looking at his phone. And then he naps during the day, and he just has a tough time. He also has been diagnosed with restless leg syndrome. He went to the sleep clinic.
Mm-hmm.
And so I'm interested in the chronotherapy. Do you think that might be useful for him, and how can I find out more about it?
Yeah, I mean, it's hard to know. I mean, it sounds like he just has some, I guess I would call bad habits. I mean, he needs to get away from the screens, right?
Right.
I mean, the chronotherapy would be one option, but unless he creates an environment that, is where he's away from the light when he needs to be away from the light, the chronotherapy, he's just going to keep spinning, So I think it's more behavioral intervention than the chronotherapy.
Okay, I will share this information with him. He does take melatonin, and that helps a little, but not enough.
Some of the melatonin, you have to take it at the right time too. So yeah.
Well, he's discovered he needs to take it hours before.
Yeah, that's right.
Thinks he's going to sleep.
Yeah.
Thank you.
Sure.
Well, Nancy, I want to thank you so much. This has been really fascinating, and I think all of us have learned a lot, and I think it will probably do a lot of us good as we examine our own sleep. So thank you very much.